Faisal has very beautifully shown, once you do the UBM, how to interpret it, right? So now we will look at what are the clinical correlations and how do we interpret the diseases. So congenital glaucoma is not very uncommon in our country, and we don't see a very clear cornea. So which means that majority of the time we see eyes with very, very hazy corneas, and sometimes we... Kya problem hai? Sorry about that. So anyway, let him connect it. So we do see patients presenting with very severe corneal haze, which means that there's grade 4 or 5 corneal edema, and we do not see what is happening underneath. All we know is there's elevated intraocular pressure, there are large eyes, and we know that there is glaucoma. We have to go ahead and do the surgery. But until we operate and the cornea clears, we do not know what lies underneath. So while it is a mystery and we do not know what to expect, the prognosis obviously will depend upon what is there underneath. It is not necessary for you to operate and then come to a conclusion as to what the condition is. We should be able to diagnose it pre-operatively. And we also have to remember that not just primary glaucomas, several types of secondary developmental glaucomas also can present with corneal haze, sometimes partially, sometimes completely. So when you have an eye like this with a cloudy cornea, and that is sudden presentation of whiteness in the eye, the parents bring the child to the emergency, but we need to understand what is underlying this. Okay, is this an aniridia? Is this an iridocorneal adhesion? Is this something else? Those things. Timer on kiya hai, nikal dijiye usko. Okay, so there is a very beautiful article that was published by Ken Nischel's group, which looked at clinicopathological correlation and also looked at what features were there on ultrasound biomicroscopy, and they correlated with the clinical diagnosis. What was very interesting was, of the group of patients that they had seen, close to about 38% of the eyes, the clinical diagnosis changed after the UBM, and majority of those where there was a difference in this clinical and the UBM diagnosis matched with histopathology, which means that you cannot have a better confirmation than that. So UBM is definitely necessary to make a diagnosis in most of the conditions. So it helps to establish diagnosis and also plan appropriate treatment. A couple of examples that I will show. A 1-month-old child presenting with hazy cornea, elevated IOP, enlarged corneal diameter, irregular anterior chamber depth. So if we partly see it and we know that there is some irregularity in the anterior chamber depth, we do not know what the condition is. UBM clearly shows that there are iridocorneal adhesions, there are multiple pockets, and most likely this is something that you're dealing with, congenital iris cyst. So similar kind of presentation that you see in a little older child, but the irregular anterior chamber depth is more of peripheral rather than central, and you see that there are iridocorneal adhesions and angle is completely closed. This child has Axenfeld-Rieger anomaly. So these two conditions that we just saw, who may have irregular anterior chamber depth with iridocorneal adhesions, but even before we could take the baby up for an examination under anesthesia or operate them, we will be able to understand the diagnosis prior and possibly prognosticate and plan your treatment better. This was a child who was a 4-month-old, again presented as congenital glaucoma. So everybody has enlarged corneal diameter, some of them have HABS striae, and when we did a UBM, there was no gap between the iris and the cornea. The entire iris was stuck to the cornea, and what you're seeing here posteriorly is the lens. So this patient has a if you on a cursory examination, it looks as if there is a deep anterior chamber. Deep anterior chamber, that's because the iris is stuck to the cornea. I think interpreting the structures, which Faisal just alluded to, is very, very important. And this patient actually had persistent pupillary membrane with pupillary block and secondary developmental glaucoma, required a pupilloplasty along with a trab and trab. And this child had deep anterior chamber after the surgery, cornea cleared, and intraocular pressures to a great extent were controlled. So it also helps to rule out diagnosis. So this was a baby referred again as congenital glaucoma for surgery. There was mild corneal haze in one eye, diagnosed as PCG and referred for surgery. The corneal diameters were increased. Right was little more than the left. But on examination, the child had a CD ratio of 0.2, intraocular pressures were 2. So here I don't think we are dealing with glaucoma. Sometimes you may be wrong because you may have low IOP, maybe because of corneal edema, but because the enlarged corneal diameter is accommodating for the raised intraocular pressure, you may not be able to record the IOP. Base scan showed attached retina, but the lens reflexes were slightly deviant from its normal position. This is the UBM that shows flat iris and a very, very concave iris in the contralateral eye. This baby had bilateral subluxated lenses. One of the visits, when we were waiting for the surgery and baby was coming in for a PAC checkup, the lens had displaced into the anterior chamber. So what was this condition? This condition, we did a genetic testing after that. It is a very clear congenital megalocornea with spirophakia that can present with secondary glaucoma, and here the treatment is not to go and do a glaucoma surgery but to remove the lens. So it will help you to diagnose appropriately and do an appropriate treatment, because most often Arif Khan has very beautifully written in his articles that if you go and do a glaucoma surgery in these eyes, you will end up having an RD and lose the eye. Okay, so you should not touch these eyes. Sometimes you have unusual clinical presentation. This was a patient who had a post-operative extensive choroidal detachment, although this is deviating from congenital glaucoma. I thought I should show you this. This patient had choroidal detachment, but just see the CD there. You see those fibrillar material there. That was very, very unusual. This looked like an end-off. In fact, on the clinical, when the retina surgeon saw, he said, this looks very abnormal. I think this is we are dealing with a chronic endophthalmitis. But this patient had a CD with extensive inflammatory membranes. This patient required steroids, and after that it completely resolved, and you can see that everything became, as if nothing happened to this eye. So sometimes it also helps to interpret. This is again a picture not of congenital glaucoma, but we do deal with these cases. Young patient, elevated IOP, aphakic. In aphakics, to understand a pupillary block is extremely difficult. This patient actually had a pupillary block. You can see the peripheral tenting of the iris, but if you just look at the anterior chamber depth, it's quite deep. You will not be able to diagnose it. So this patient underwent a PI, and after that you can see the flattening of the iris contour there. So it helps you to understand what is happening under the iris in certain conditions. Again, this is Peters anomaly. It looks, everybody knows what this condition is, but whether there are just iridocorneal adhesions, iridocorneal lenticular adhesions is something that is very important for us, so that it helps you to prognosticate as well as plan your surgery. Primary congenital aphakia, again we know it's a clinical diagnosis. If any of us have seen this case once, I don't think we will ever miss it. We know how the corneas look pearly white, and these eyes are usually small, axon lengths are very small. If the eye is larger in size, if there is an asymmetry in the size, then you know you're dealing with glaucoma here. And B-scan, of course, you will not be able to see a lens placode, but the UBM helps you to understand as well the anterior insertion of the iris ciliary body as well as the absence of the lens in its position. So this is again very important. Sometimes clinically these conditions are quite obvious. Nobody need to tell you what this condition is, but what UBM helps you to understand is what is the relationship between the iris and the cornea. Is there a Descemet's detachment that you are dealing with? Is there an iridocorneal adhesion? How extensive it is? That will help you to plan what type of surgery one needs to do. So this, I don't want to go into the details. Faisal again showed this. It also helps you to make surgical decisions. What type of surgery would work in certain patients? So this is again something that he alluded to. She's article very beautifully showed this, based on the severity of trabecular dysgenesis, how the angle-based surgery would help. So this is something that's very important. In a severe dysgenetic angle, maybe one need to go in for a filtration surgery rather than doing an angle surgery. Ciliary body cysts and tumors is something that we have to be worried about as well. Sometimes they can present as congenital glaucoma also. So that's why it is a routine for us to do a B-scan for every child who presents with congenital glaucoma. Even if the cornea is not so hazy, we will not be able to make a complete posterior segment assessment. So B-scan becomes very important. This was a young girl again presented with neovascular glaucoma unilateral fundus. Obviously we couldn't see anything abnormal. UBM showed a tumor. Okay, so this child had a medulloepithelioma that had to be treated. Also helps you to follow up. Once treated, the tumor just melted, and this child had useful vision, and we had to take care of the intraocular pressures as well. Of course, there are limitations. We need to understand that anything that is deeper than 4 mm, we will not be able to get it. You need to do a proper evaluation. You need an experienced operator to do this. We have to be very, very careful in doing UBM in a child, especially when the child is uncooperative. You may hurt the eye. So to conclude, I would say UBM is very, very important and definitely plays an adjunctive role in establishing the diagnosis in patients with cloudy corneas, not just in cloudy corneas, also in those with clear corneas, where you will be able to make a proper diagnosis as well as follow them up once the evaluation is done and after an intervention is done. Also sometimes helps you to, let's say for a spirophakia, once you know what the condition is, or an aniridia, you will be able to do a systemic evaluation and possibly help the child in multiple other ways as well, and prognosticate and help the patients. Thank you so much for your patient hearing.
Thank you so much, Dr. Sirisha, for putting that up together.